Fine, fine, sure.
Okay, okay. Fine.
Okay, ma'am.
Yes, Shreyanshi. Shreyanshi,
Yes, yes, ma'am.
we can
Shall we
start.
start?
Madam
Yeah.
has
Yeah.
joined. Yes, yes.
Okay, okay.
Because my laptop was taking time, I said, let me just.
Okay, okay, ma'am. No issue.
Okay.
So with all your permission, I'm starting the session. Good afternoon and a warm welcome to all the dignitaries present here. I'm Sreyushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event hosted by the National Neonatology Forum, Gujarat, and the focus of today's session is case presentation neonatal anemia. So let's begin today's session, for which I would like to invite Dr. Swetal Bhatt ma'am to take over. Ma'am, kindly proceed with the talk. Over to you.
Thank you, Shreyanshi. Good afternoon, all, and welcome to the one more session of Neonatal Pathshala. We are going ahead strongly and steadily with a perseverance each Wednesday, even if there is a flood, and any one of the team member is taking up, and the Neonatal Pathshala goes on. So today we have a case presentation on neonatal anemia. And as we miss our mentor, Dr. Sheila Madam, so much that we thought whenever we have a difficult case, we used to go in her office with the case and to discuss it out. So this neonatal anemia case was really a one of the difficult to come to the conclusion. So we thought of taking up this case on neonatal Pathshala and calling our own mentor again as an expert faculty. Thank you so much, Dr. Sheila ma'am, for consenting to be an expert faculty for this case. And Dr. Rachna is going to present. So over to Hitesh. Please introduce our expert faculty.
Yeah. Thank you so much, ma'am. Welcome all of you. And today in Neonatal Pathshala, we are going to discuss this interesting case presented by Dr. Dachna Gohil. It is about neonatal anemia. So we are having as an expert Dr. Sheila ma'am. As we all know, she doesn't require any formal introduction. She worked as a professor and a head of department in Baroda Medical College. She is an excellent teacher. We, as a resident doctor, pediatrician, neonatologist, and consultant, has gained so much knowledge throughout these years, and either directly or by indirectly in terms of sharing knowledge and having an experience from her. So she is a course coordinator for in various IAP program of neonatology fellowship at SSG Hospital. She has a special area of interest in neonatal nutrition, growth and development, as and she established a human milk bank at SSG Hospital also. So I request ma'am to impart her knowledge with her experience uh, related to this topic during the presentation by Dr. Rachna Gohil. So without wasting a time, I would like to welcome Dr. Rachna Gohil to start this session. And I will request the viewer also, if there is any query, question, or comment, they can share in a chat box so that we can discuss it with our expert also. So over to Dr. Rachna Gohil for the presentation.
Rachna, are you ready? रचना स्लाइड शो कर दे
हाँ अथवा नीचे थी फुल स्क्रीन कर दे
यस
हाँ बस बस
Everyone, I'm presenting a case on neonatal anemia under guidance of Dr. Shwetajan and Dr. Jay.
Rachna's audio is not clear.
રચના તારો ઓડિયો અવાજ નથી આવતો
એમ હવે આવે છે
હજી બહુ જ ધીમો આવે છે
બહુ જ સ્લો જાણે તું દૂર દૂરથી વાત કરતી હોય ને એવું આવે છે રચના ફૂલ સ્ક્રીન કરી દે હા હા ઓકે યસ 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 ચાલ
હવે
ફૂલ સ્ક્રીન કરી દે પહેલા હા
History presenting case of female newborn child, baby of XYZ with a maturity of 30 weeks gestational age and a birth weight of 1.09 kg, which falls between 3rd to 10th centile. The baby was born vaginally at SSG Hospital. Antenatal history, the mother maternal age was 30 years with a weight 45 kg, height of 135 centimeter, which is short stature with a BMI of 24.7 kilogram per meter square. Gravida status of the mother was second gravida, para 1, living 0, dead 1. The first gravida was IUFD at 6 months of gestational age, which was 1 year ago. Maternal HB at the time of delivery was 10.3 gram percentage and sickling was negative. This blood group was A positive. History of any blood transfusion in the past or no known hemolytic disease in the family. Mother was a booked case at SSD Hospital. She has taken 5 antenatal visits. During first trimester, pregnancy was detected by a urine pregnancy test at home. Last menstrual period date was not known. However, all the scans were done. Folic acid supplements were taken during the first trimester. There is no history of any hyperemesis or fever with rash. There is no history of any intake of teratogenic drugs or radiation exposure during the first trimester. In the second trimester, anomaly scan was normal. Mother has perceived fetal movements since 5th month of gestation. She is immunized adequately for tetanus. Iron, folic acid, and calcium supplements were taken. The third trimester scan was done, which showed Liker was adequate. There was no other abnormalities noted in the antenatal scan. Mother has no complaints of reduced fetal movements or premature rupture of membranes. There is no history of any maternal fever or foul-smelling discharge. No history of hypertension or gestational diabetes. The mother presented to SSG Hospital on 18th of August with premature labor pain for 2 hours. A single dose of antenatal steroid was given 1 hour before the delivery. Mother delivered vaginally. The baby cried immediately after birth. Delayed cord clamping was done. Initial steps of resuscitation were done and baby was shifted to NICU in the transport incubator. There was no history of placental abruption or vesa previa that was noted. There was no history of any accidental bleeding from the umbilical cord. Initially, baby was kept on CPAP with a PEEP of 7, flow of 6 liter per minute with an FiO2 of 50%, but the SS score was 6/10 and saturation was only 86 even after 15 to 20 minutes of CPAP. Hence, baby was shifted to IMV mode of ventilation, which required FiO2 of 70% with pressures of 18/6. After 15 minutes of invasive ventilation, SS score was 4/10 and SpO2 had improved to 92%. Temperature, baby was euthermic. There was tachycardia with a heart rate of 168 beats per minute. Respiratory rate was 68. SpO2 was 94%. There was no signs of shock. RBS was normal. Pulses were well palpable. Peripheries were warm. There was significant pallor noticed on clinical examination along with pedal edema that extended up to the ankle. Anterior fontanelle was at level. On per abdomen examination, liver was palpable 1 centimeter below the right costal margin. The chest X-ray done at birth showed signs of HMD with air bronchogram and homogeneous ground glass opacities bilaterally. At 6th hour of life, the child had tachycardia with FiO2 requirement of 65%. With the same pressure requirement, no signs of shock, pedal edema present. The investigation was sent at 2nd hour of life, revealed a hemoglobin of 8.2%. with a total count of 16,200 and platelets of 1.5 lakh. USG head was suggestive of GMH grade 1 and USG abdomen had free fluid. Considering anemia at 2nd hour of life and tachycardia with pedal edema and impending CCF, we had decided to transfuse 1 PCV. IV fluids and MEN feeds were given. First line antibiotics were started and first PCV was given at 12th hour of life. The other investigation showed a bilirubin, which was sent at 2nd hour of life, showed a total bilirubin of 3.4 milligram per deciliter with indirect component 1.8. LDH was 897, slightly increased. Retic count was 7%, which is normal for this premature newborn. Up to 10% could be seen at birth. Blood group of the baby was O positive. Maternal ICT was negative, DCT was negative. We had done a minor blood group incompatibility, which was also not present. In the red cell indices, MCV, MCH, MCHC were all normal with a slightly increased RDW. In the peripheral smear, there is mild anisopoikilocytosis with normocytic normochromic RBCs. Occasional erythrocytes were seen. Otherwise, CRP was 12, RPR was non-reactive and TSH was normal. The serum bilirubin levels of the baby required phototherapy for at least 5 to 6 days, following which the bilirubin level reduced to out of the phototherapy threshold. At 24 hours of life, after the PCV, 12 hours after the PCV transfusion, the heart rate had settled down to 154. There were no signs of shock. Pallor was still present and pedal edema had reduced compared to earlier. The FiO2 requirement has dropped down from 65 to 50% with pressures of 17/6. At 36 hours of life, baby again had tachycardia with 174 heart rate, hyperdynamic precordium and dorsalis pedis was palpable, not bounding. 2D showed mild PDA, there were no signs of HSPDA, and post-transfusion hemoglobin was 8.8 gram percentage. We had given a second PCV transfusion 48 hours after the first transfusion. At 70 hours of life, child had improved with, there was pallor had reduced, pedal edema was absent, heart rate had settled, and in mechanical ventilation, the FiO2 requirement had dropped down to 25% with pressures of 17/6. At 76 hours of life, the baby had worsened in form of worsening distress with an increase in FiO2 from 21% to 40%. There were no signs of shock. We repeated a septic screen which showed a fall in the total count to 4,300 with a CRP of 15 milligram per deciliter, and the chest X-ray showed a right-sided pneumonia. This is the chest X-ray done on worsening. Considering ventilator-associated pneumonia, we had stepped up the antibiotics and continued invasive ventilation. 48 hours after the event, the baby had improved. There were no signs of shock. We are again able to taper the FiO2 to 21% and we plan to wean off on NIMV. At 5th day of life, that is 110 hours of life, baby had 2 episodes of yellowish vomiting with increase in abdominal girth by 2.5 centimeter and more than 100% of RT aspirate. Stool occult blood was also positive and X-ray abdomen was showing dilated bowel loops. So considering NEC, we had made the child nil per oral along with IV fluids, and metronidazole was added. We had continued with non-invasive mode of NIMV mode of ventilation. At 6th day of life, we were able to taper off the ventilatory mode to CPAP. NBM was continued and antibiotics given. We started MEN feed at 7th day of life after 48 hours of NBM. Baby had tolerated MEN feeds well. On 8th day, we were able to give a trial of CPAP and the baby tolerated the trial well. At the 9th day of life, yes, ma'am.
Rachna,
Yes, ma'am.
yes, you're going through the courses, but could we just take a stop here? Day
Yes, ma'am.
one, when you received, what was your clinical diagnosis? And what did you consider
Ma'am.
as a cause, probable cause of anemia here?
Ma'am, at day
Because
one,
yes,
because
the
there was
baby
a
had anemia, baby had
retic count was
transfusion, then we had typical preterm complications and infection, pneumonia. So other things added to it later. But day one, this baby had an HP of 8.2 for a 30 weeks gestation. She went
Yes.
into spontaneous preterm labor. Any data from obstetrician
ma'am.
about your antenatal? You said yes, there is no APH. But what else can cause anemia
Yes,
at
ma'am.
birth?
Ma'am, there could be a chronic feto-maternal bleeding, which would have gone unnoticed, which would have led to fetal anemia,
So what
or
are the
any congenital
four
infection.
events which can be documented for feto-maternal hemorrhage? Because yes, it is not easy to perceive unless until looked for. So what
We can look.
yes.
We can do Clay or Bedke test on the maternal blood. We can look for
If
fetal
we have to do
DNA in the
something
maternal blood.
antenatally, can you think of?
We can do the MCA Doppler and look for the velocities in that. If they are more than 1.5 medians of multiples
that
of
is one
median, that
thing.
is normal. If it is going,
Yes. Anything else? Okay. So decreased fetal movements, fetal anemia and undergoing would have decreased fetal movements. So probably this was an unbooked case.
no, this was a booked case at our hospital itself.
Okay. Any USG Doppler findings?
USG was done at 26 week of gestation, which was normal. Liker was adequate, and the fetal growth was normal for that period.
Okay, fetal growth at that point. Another that mother didn't perceive any decreased fetal movements or anything before coming. Okay, it was
No,
an
ma'am.
her
She just
first
came for it.
delivery was also a preterm labor.
Yes, that delivery was at 6 months of gestational age.
So probably it was more like just IUFD, but just post second trimester. Okay. And then
Yes,
so
ma'am.
and mother had otherwise no reason for that IUFD. Why I am asking is
No.
first time also a pregnancy lost, second time going into a preterm labor with anemia. Should we suspect something?
It could be congenital infections that would have led to this. It could be maternal syphilis could also sometimes present like this, or some storage disorder. Or there could be immune.
Before that, maternal syphilis, could we have got some more thing? She was screened, she was antenatally booked, so probably ruled out.
Yes, ma'am.
VDRL would have been negative in mother.
Yes,
What was
ma'am.
her HbA1c HIV status? Negative.
Yes, ma'am.
Which are the ones which in the first or second trimester can cause anemia? Now, the infections.
Ma'am, parvovirus infection and cytomegalovirus can also cause sometimes.
Okay. Did you have something more in this baby which could probably tell you that baby had infection?
No.
Edema. At 30 weeks gestation, you had significant edema. What does parvo ultimately cause along with anemia? Yes, there was one thing which was not very evident, was you didn't have a very low platelet amongst your cell line.
There was only.
You never saw that. Your initial white cell also were not very low. What was your cardiac status?
16,000.
Cardiac status.
Cardiac status was normal. Later on, after 36 hours, child had a hyperdynamic precordium. So we had done a 2D echo for that. The ventricular function was also good, and there was only mild PDA. Otherwise, the cardiac functions were normal.
Okay, because some of these viral infections can have pericardial effusion along with it. That's what I would. So, okay, what you said is one is infection, still doesn't get totally ruled out, remains as a possibility, congenital infections. Which are the other causes? Day one when you have anemia.
There could be hemolytic jaundice when the mother is already sensitized with maternal antibodies are present, which could lead to hemolysis in the
Probably
fetus.
something which your investigations are suggesting it is not. So, probably you don't have any kind of minor or major group, because you did look for uncommon blood group incompatibility also, isn't it? Okay.
Yes, ma'am. Yes.
So now what are you left with when you have an anemia like this at birth? Would you call it microcytic or a normocytic normochromic anemia? You had indices with you.
Normochromic.
Okay. In newborns, when do we call it microcytic?
Yes, ma'am. Indices were normal and
in newborn, when do we call it microcytic or macrocytic?
The MCV.
Yes. Of what value?
And the MCV is more than 100 is microcytic.
No, that goes for older children. For newborn, your normal MCV would be 100 to 130 in neonatal period, while MCV less than 90 would put it as microcytic, and macrocytic would be more than 130 MCV. Okay, so the parameters do change in newborn for your micro, and so probably yes. What was your MCV here?
94, man.
There's some more discussion which is left, but I think we can quickly finish your summary till what did you where did you end up at the end before we get into approach and differential diagnosis of anemia. Okay, we would try to limit our discussion to anemia today, as that has been a focus of discussion. But you could just quickly summarize your further course and the outcome.
Yes. At 9th day of life, baby had one episode of apnea, not responding to stimulation and requiring CPAP support. We had given CPAP on 21% FR2 with 5 PEEP and 5-liter fluid, and we continued with IV fluids and feed with antibiotics and Kefiret. Today, baby is 16th day old with a corrected gestational age of 32 plus 6 weeks. All the vital parameters are within normal limits. There is no hepatomegaly or pedal edema at present. Clinically, pallor is present. Child is currently on full IG feeds at 180 ml per kg per day with human milk fortifier. Antibiotics have been continued. We are continuing with Kefiret and KMC with EBM swabbling. The latest investigation, which was done on 12th day of life, showed.
Did your blood culture grow anything? Okay. Did your acute markers?
No, ma'am. Culture showed no growth.
And were the acute markers rising up with infection?
No, ma'am. The initial CRP was 12. Repeat CRP was 15. It did not increase.
So there was not a marked increase in your viral, acute inflammatory markers also. Okay.
Yes, ma'am. Platelet counts have also been within the normal limits, more than 1.5 lakh. So summarizing, the baby was a single preterm 30-weeker, 1.09 kg female, SFD shell, vaginally delivered, cried immediately after birth with a clear liquor, maternal morbidity of anemia and short stature, with neonatal anemia requiring 2 PCV transfusion under investigation, with neonatal jaundice requiring phototherapy for 5 days, with ventilator-associated pneumonia and NEC grade 1. The differential diagnosis is thought were chronic feto-maternal bleeding, enzyme deficiency like G6PD or pyruvate kinase, torch infection, hemolytic jaundice, and minor blood group incompatibility. We have done the workup for that. Torch titer we have sent, report is pending.
Okay. So this is the okay. So one thing, by cell morphology, we are putting this, that you had an early, what would you call it? Definitely an early onset anemia? Because
Yes, ma'am.
neonatal anemia, your causes differ depending on the onset.
Yes,
Okay.
ma'am.
So amongst the early onset, what are your causes? Early onset, normocytic, normochromic.
Because it is normocytic, normochromic, it could be due to secondary to some blood loss, which was unnoticed, or some
Okay, some of the
hemolytic
things
cause
which
could
you
still
could
be
have
present.
clarified on examination are like, was there any subgaleal hemorrhage, any scalp
No.
edema and subaponeurotic hemorrhage? Because they do
No.
have a lot of blood
Present.
loss and present as anemia. So on clinical examination,
Hemolytic,
you should specifically rule out that there was no, as you had edema down
Yes.
there, if whether there was any subaponeurotic or subgaleal collection or not. Okay. Was the cord looked at?
Sorry,
What
ma'am.
can cause acute anemia in a newborn? What kind of cord accidents?
Ma'am, vasa previa, which could lead to a bleeding, or if there is just the umbilical cord would have got unclamped accidentally, would have led to some blood loss,
Or cord
or
avulsion?
any avulsion of the cord.
Cord, yes, that can also cause. You had only grade 1 hemorrhage. Along with what, any other site that you would look for cause for anemia? Cephalometoma, you said wasn't there. Where else?
In the abdomen, there could have been some bleeding, but it was.
Yes, so probably any adrenal hemorrhage or anything else somewhere. You didn't have any pulmonary hemorrhage, isn't it?
No, ma'am.
Okay.
No, ma'am.
During NEC, you had occult blood, but did you have frank blood? But that
No,
again
ma'am,
would
there
come
was
to
no.
your later on anemia causes, not on day 1 at birth, isn't it? Okay.
Yes,
Then,
ma'am.
so what are the ways by which you can confirm feto-maternal hemorrhage? One is, you said, clear Bedke count. Is it easy?
No.
How is it done?
It is done with the help of a reagent and.
Yes, so what you are looking at is in maternal, then you have to quantify it also. Because when it goes into a large amount, then only it becomes the cause. And many times it's missed. What is the other alternative, which, and the calculations and the formulas that are there now, that how much blood loss would have occurred, they are little complicated. They're not simple that you send it and clear Bedke count this much. That's why your blood loss is this. Is not that weeks of gestation and the volume of blood of the fetus, on that it is calculated. Which is the other test that can be done nowadays being preferred?
Fetal cell-free DNA is checked in the maternal blood.
Flow cytometry can be done. Okay. In the maternal blood. Flow cytometry, and then try to identify. Again, one has to then put calculation into that whether this could be. Yes, if there is a sensitization, the even small amount of that can help you. But when you do not have sensitization, it's only the maternal hemorrhage, means feto-maternal hemorrhage leading to anemia, then you need the calculations to tell you that how much of feto-maternal hemorrhage. You have sent torch. You have sent parvo?
No, maybe we have sent only the torch titer.
Okay. Do you have anything else which fits into torch?
No, ma'am. We have done a fundus examination, which is normal. Other than that, there are no other clinical features.
Yeah,
except for there is no hepatosplenomegaly, there is jaundice and anemia.
Yes, anemias due to torch, other than syphilis or this, they do come more in second week or later. At birth to have anemia, parvo is the commonest one where you could have. So anemia, that still remains a possibility. So now you have this case where how have you ruled out hemolytic? No, you haven't ruled out. No? You are putting hemolytic anemia still in picture. What were the things which were telling you that this could be hemolytic?
Ma'am, because there was anemia along with jaundice, as in the bilirubin levels were within the phototherapy range since birth, and it extended up to at least 6 days. Plus, the LDH was slightly on the higher side, and the retic counts were not decreased. Retic counts were normal.
So which are the hemolytics which would present?
Mostly it is ABO and RH incompatibility, which we have ruled out. Then there could be spherocytosis or elliptocytosis, which was not seen in our peripheral smear. Apart from this, there could be enzyme deficiency like G6PD or pyruvate kinase deficiency, which would present with hemolytic jaundice. But G6PD, our patient is a female child.
So in
it
rare
is
circumstances,
less likely.
Yes. But again, at birth, when do usually your enzymopathies come up?
Later on after.
Maybe it is because at birth, usually you would end up either something is decreased production, which already occurred intrinsically, or you had increased destructions, which had started, isn't it? But still, yes, you could keep. Now, what is your current retic? If you are thinking in terms of hemolytic, you had borderline at that time, you are saying. Now, at the end of second week, where is your retic? Has it repeated? We have not. Probably we need to monitor because as we have not reached, if we rule out everything, it doesn't turn out to be, and now the child remains stable. Probably I might go towards feto-maternal hemorrhage as a possibility when you do not have. This mother had any history of any other infection or she has any? This? No. But if we are ruling out infection, I would say parvo needs to be ruled out here. Okay, more than torch.
Yes, ma'am. Yes.
Because that little edema which was little out of proportion, anemia, tachycardia, and your respiratory embarrassment requiring ventilation for a long time, all those things. Because after that, one more time you required transfusion. Other than that, you did not require. Okay. No, can we just quickly go through how would you classify anemia in newborn? One is, I said, early onset, late onset. So this case was fitting into early onset. Yes. In early onset, you almost gave all the causes that you had. You looked at the examination. Now, which are the late onset causes? After, when do you call it late onset and when do you call it early onset?
Early onset within the first two weeks and late onset after that.
No. Early onset is in first 7 days and late onset is after first week. Okay? Because by that time, many things play a role. So we don't take a big period of 2 weeks. There could be somebody else classifying out some other. Classification that I'm aware of is first week and after first week. Yes, so what are the causes of after first week, which we all should keep in mind when we start investigating a child for anemia? Your baby had out of that one or two things.
After first week is hemolytic causes are the common ones. The ABO incompatibility, RH incompatibility could still be present. There could be a germinal matrix hemorrhage or an intraventricular hemorrhage, which is common.
More than germinal matrix would not cause that significant anemia, but beyond grade 2 would definitely. Yes. More commoner, yes, your ABO is
pulmonary hemorrhage could.
Okay. Then, what is the biggest threat that we usually see in these babies in our NICUs? Sepsis. Yes. Sepsis, NEC. Then, which are the other causes?
DIC.
Yes. Then, your bloodlet. If the baby has been sick in the first week, and then you have a lot of bloodlet because of the sick, that would also cause anemia. Okay, normally forgotten very easily. We all end up transfusing these babies. Then sepsis, NEC, bloodlet, then what are the other causes that you would start thinking that when anemia is persisting or anemia is not getting corrected, you're not hitting upon the cause?
The congenital infections could be considered at this time.
Okay, yes.
Hemoglobinopathies can also be seen.
Okay, which are the ones which can cause it amongst the hemoglobinopathies?
Alpha hemoglobinopathies or gamma hemoglobinopathies could present in this age group.
Okay, yes. Your enzymopathies, your G6PD and pyruvate, time in the first week or in the late onset. Then all your RBC morphology disorders, spherocytosis, elliptocytosis. Okay.
Yes,
Any other which occurs in now after first week or after second week, third week, when you are ready to discharge a preterm?
Anemia of prematurity could be seen because of physiological nadir of
yes, anemia of prematurity, anemia of nutritional deficiencies also can start coming up. Okay, your B12, your other things, and then some of the other ones are your endocrine. Which ones? Hypothyroidism. After second week, that can also come up. If this baby was Down syndrome and had anemia, what would you think of?
Congenital leukemia or something.
For that, but you didn't have any count which was high. Wasn't there, na?
No.
Then even liver disorders, all your liver cell failure, renal failure, they would now start manifesting as anemia by second week, third week, if the baby is a sick newborn in your NIC. Okay, so other causes also would end into it. If it's not G6PD, does pyruvate kinase manifest?
Yes, ma'am, it could manifest in the neonatal period, but something presenting at birth is rare. It would probably present towards the end of first week.
And one more thing, it's not very easy to pick up that enzyme. So most of the time you require gene studies also to be done. Okay.
Done.
You have put this slide of causes of non-immune hydrops. What were you looking for?
Because our first ABO and RH incompatibility was not present, we ruled them out. So we are looking for other causes which would have led to the edema and all. We ruled out it could be Turner syndrome. Cardiovascular, we had ruled out. We had done a 2D echo. The other hematological causes are alpha thalassemia, then parvovirus,
but to call it
cytomegalovirus.
Non-immune hydrops, what you should have had? The definition of hydrops.
There has to be collection of free fluid in at least 2 or more of the body spaces. One could be a skin edema and collection in either pleural effusion, pericardial effusion, or ascitic collection.
Yes,
and
then it would have made very important
also, which would
that your one of the parvo, because parvo manifests like that, but you didn't have in any of the cavities your fluid. So a definition of hydrops really doesn't fit into this child so well, other than this. Okay. Now this child, while growing, you realize that the child's retic is increasing and hemoglobin is falling.
There could be some occult blood loss.
Where?
In the gastrointestinal tract, because the child is growing otherwise stable and still having a falling hemoglobin with an increasing retic.
Which are the babies who would have GI blood loss? Causes of GI blood loss in a growing prem.
NEC, but that would be not
that already.
persistently
I think
ongoing.
we are going to be running short because I was asked that we have to wind up our session. So one, as I told you, probably your case was of a neonatal anemia of early onset with a normocytic normochromic anemia. Probably, definitely, fetal-maternal hemorrhage does remain as a probable cause, and infection like parvo, I would still keep in mind as a cause of anemia, and some of those other blood losses at peripartum which got missed, as probably we do not have details with us. Still, a follow-up is something which would tell us. Now, I have one pertinent question which every person who transfuses the baby or a neonate should keep in mind. So, what are the complications associated with neonatal transfusions? The routine mismatch and all, I agree, is going to occur in anybody. Okay. So, I'm looking at which are the important ones for newborns that we would keep in mind.
One is fluid overload.
So what
could
is
be
it
present.
called, as you know? What is the short form used for it?
Transfusion associated circulatory overload.
So TACO.
TAC
It's
or
not Taco Bell, but it is TACO. More of quiz question, but I'm just reminding you of that. Okay, then
then
one is
ma'am,
TACO, then
transfusion associated lung injury.
so trolley. Okay, then
Then transfusion issue associated gut gastrointestinal tract injury.
okay, and what else? What increases when you have to transfuse 1, 2, or 3? What should be monitored?
Calcium, potassium.
Potassium. Hyperkalemia is a very, very important. And what the percentage increase in ROP occurs when you transfuse within first week? Any idea? And why does it occur?
Because after transfusion, there is more oxygen delivery because the oxygen releasing capacity would be more. To lead to injury to the developing retinal vessels by free radicals.
So here, like, it's a life and death, so you don't, but definitely for the other factors to be controlled as well as to be monitored in such babies is very important, that even your ROP. And what is the transfusion associated gut injury?
Because of transfusion, there will be an injury to the mucosa.
Transfusion causing injury to mucosa?
During transfusion, if there is any feeding.
So we do stop feeding. There is already a big controversy whether one should or not. And there is a major trial also being of the, and results of it are just awaited. But so how does it cause an increased incidence of NEC? Any idea? Increase in mesenteric and pulmonary vasoreactivity. Okay, so it's the mesenteric artery and the flow into mesenteric artery which gets affected, not the gut mucosa. And in turn, probably injury to the gut and necrotizing enterocolitis. Okay, an interesting case, but definitely I would would want you to repeat retic count. Okay. You should look at the ferritin level because you had 2 transfusions. So whether you need to start early iron in this baby or not, and evidence of hemolysis. Okay. So that would probably.
Sure, ma'am. Ma'am, we should go for parvovirus investigation.
કરાવી શકાય કારણ કે હજી જો તમે ત્યાં ને ત્યાં 2 ટ્રાન્સફ્યુઝન પછી ફર્ધર ફોલ નથી, હવે વચ્ચે જે NEC ને કારણે કે સેપ્સિસ ને કારણે તમને પેલું કાઉન્ટ લો થયું હતું એવું લાગતું હતું, પણ અધરવાઇઝ low platelet or anemia alone can be associated with parvo.
Okay. Sure.
Because this child is at SGA for gestation,
Yes.
Anemia. And this mother has lost first child also at 24, 26 weeks,
Yes, ma'am.
which was making me a little concerned. What has been, is it because before 32 weeks, what fetal-maternal hemorrhage occurs, no? It can lead to fetal demise. It can lead to fetal hydrops due to anemia. It can lead to neonatal anemia.
Okay.
But flow cytometry and clear Betke count, only few labs, because and the calculations are very, very, had they done a Doppler, MCA was low, those things would have told us whether the baby was anemic earlier or not, before delivery itself.
Okay, ma'am.
So now fetal-maternal hemorrhage for us to prove becomes a little difficult, but at least
Yes.
parvo we can rule out and then monitor the baby.
Done. Okay, ma'am. Thank you so much, ma'am. It was an extensive discussion, and I must say, Rachna has prepared this in very short time. Yesterday, she was a part of a postgraduate quiz of IIP, and today she is presenting. So,
Well presented, well presented.
commendable
And,
presentation, yes. And
I
ma'am,
think one
again,
more thing, the peripheral smear also can be now again looked at it. I know transfused cells might alter a little bit, but then they can look
yes,
at it and a proper retic count.
yes, we will be following this patient, and definitely I'll update you, ma'am. Today we really felt that we are again back to our own era of baby room, where we used to come with the difficult case with you, and it was really a great discussion. Some of the points which you have pointed us, that we will take into account when further whenever we come across the case of neonatal anemia. Thank you so much, madam, for your expert experience sharing as well as detailed discussion for neonatal anemia. Thank you all for joining Neonatal Pathshala. Hitesh, you can wind up the session.
Yes, thank you so much, Dr. Rachna, for initiating a nice discussion. And I would like to thank all the viewers and all the persons here. And thank you so much, ma'am, Dr. Sheila, ma'am, for
Hitesh,
giving.
there are few questions on chat box. We can just have a look at it, because
Yes,
somebody
ma'am.
might have.
Yes, ma'am, I looked at it, but most
Okay.
of the things they have just gave the answers related to your
Okay.
question. So
Okay, okay.
I couldn't
That's
find
fine.
any questions.
Okay, fine, fine. Yes, that's
Fine, ma'am.
Yeah.
Okay.
Shreyansi, we can wind up the session. Shreyansi? I think she is not there.
Yeah, she's on there, I think.
Hello, Shreyansi. Hitesh, we can just wind up the session and leave the meeting.
Yeah. Fine. So basically today's session regarding the neonatal anemia that is presented by Dr. Rachna and nicely give the commented by them and shared the experience related to this special subject by Dr. Sheila ma'am. So we will again we will meet for next Wednesday with different topic, and that will be discussed and displayed in with you very soon. Also.
Thank you so much.
Yeah, Shwetal, anemia of prematurity altogether would become a different topic. And that's
Yes,
why
yes.
I didn't
Yes.
get into it, because
Yes,
then
ma'am.
the acute causes would go out
Yes,
of
yes.
the list.
We wanted to discuss anemia at birth only, ma'am.
Huh.
Anemia of prematurity is a different topic. That we will take it later on when we take a growing preterm.
Yeah, yeah.
Okay, okay. Thank you, ma'am. Thank you.
Thank you, Alok.
Thank you so much, everyone. Thank you for giving us the opportunity to host the session. Thank you.